I am Sheila Roth, Head of Education at Pearl. I am thrilled to be joined by Dr. Kim Kutsch, CEO of Oral Biotech, and Jennifer Wolfenbarger, VP of Business Development and Strategic Alliances. Before we begin, I want to set the stage with one question. What would change in your practice if you could identify and treat early decay before it turned into a cavity? And the other thing is, once we know we have a high caries patient, what do we do with them after we have filled the cavity, right? And we've all seen that in our practices. So that's what we're going to be exploring today is how to detect early disease, communicate that effectively with patients, and really, as our whole industry has moved towards implementing minimally invasive care protocols that improve the outcomes and simplify your workflow. It is my pleasure to introduce our speaker. I will let Jenny speak in just a moment here, but Dr. Kim Kutsch, a trailblazing dentist, inventor, and educator who has shaped modern preventative dentistry, graduate from University of Oregon School of Dentistry, holds 17, not 7, 17 patents, is internationally recognized speaker, past president of multiple dental organizations, and the host of the chart-topping podcast, Contrary to Ordinary. I also learned about some new books I'm going to read, Why Me and Balance, available both on Amazon and caryfreepro.com. As CEO of Oral Biotech, makers of Carie Free, Dr. Kutsch continues to lead innovation in preventative care with more than 42 years in clinical practice. And his impact on dentistry is truly remarkable. I am so honored to do this webinar with you tonight. Before we give you the floor, I'm going to turn that over to Jenny and have her kick us off, and then we'll jump right in.
Thank you, Sheila. And I just want to welcome everyone. And as Sheila said earlier, my name is Jenny Wolfenbarger. I am VP of Business Development and Strategic Alliances here at Oral Biotech. And I just like to thank you for joining us. We're excited to be partnering with Pearl to bring you this collaboration between Dr. Kutsch and Sheila Roth. Tonight, they're going to be sharing with you simple, effective ways that you can integrate prevention and minimally invasive care into your daily workflow. So we're so glad you're here. And I'll hand it off.
All right. Well, thank you. Thank you both for those kind words and the introductions. And I will open up our program. Does everybody see the slides?
Got it.
The magic worked. All right. So tonight, my part of this program is to talk about basically caries risk assessment. How do you detect those early lesions? And then, how do you make the decisions on what kind of process do you go through to treat them? Okay, and let's try and it's not moving. Here we go. Okay. So you heard my introduction. That's I've got a non-typical dental history. And oh, by the way, in case you want to know, I broke my neck on September 11th, and I broke C1 and C2, and I'm healing. So I'm wearing this fancy network for 3 months, and I'm doing well. And anyway, just wanted to let you know that what's happening there. So tonight's topic, we're going to start with caries risk assessment, and then we're going to talk about when to remineralize, when to restore. How to do that, like what are the treatment protocols for that for those early lesions, and then we're going to get into like how does AI enhance that our diagnosis and make us better at what we do. So let's start with caries risk assessment. This is a patient, actually, all these patients you're going to see were actually patients of mine. Came into my practice. She had been to her previous dentist. A year ago, he'd placed 6 anterior porcelain crowns, and a year later, 2 of them are completely gone. And, if Bob Barkley were alive, he would look at this and say, the house is on fire. And, but we see this, and it's really important for us to understand that we look at a mouth like this as dentists and hygienists, dental assistants. We look at this and we see cavities. We need to look at this and see disease. And that's the greatest challenge for us. But what I want you to do is, I think our first inclination is to sit down and go, how many cavities and where are they? And then we start already thinking about how are we going to restore those? How are we going to solve this? And because we're problem solvers. But the most important question to ask when you see a patient that has decay is why? Why do you have cavities? Because if I can figure out why you have cavities, I can figure out how to help you stop getting cavities and become decay free for life. And if I don't even ask that question, you're going to continue to get cavities until you run out of teeth or die. So dental caries, when we talk about it, it's a biofilm mediated, diet modulated, multifactorial, non-communicable dynamic disease resulting in net mineral loss of the dental hard tissues. Basically, it's caused by a biofilm dysbiosis. The diet plays a major role, is multifactorial. It's not communicable in the traditional sense, like it's not a communicable disease. Nobody's going to sneeze and you're going to get a cavity sitting next to them. But that biofilm is transmissible and transmitted from mother to child, primary caregiver to child within the family unit. And we have a tremendous amount of science on this. This is put together by a group of researchers. Everybody got their favorite words in. This was like, definition by committee. And this is the person that really influenced, I think, my education around dental caries absolutely the most. And this is Dr. Philip Marsh. He was at Leeds University and he published this. I want you to look at this. He published this in 1989. And he worked on early biofilm models and they've challenged the biofilm model with sugar. And then what they found was if they artificially kept the pH at neutral, there was no change in the biofilm. But if they allowed the sugar and the acid to take an impact on the biofilm, it changed dramatically. And, within 10 days, it already converted to a cariogenic biofilm. So the conclusion is not sugar itself, it's actually the pH that's causing the change in the biofilm. And so I met Phil 25 years ago, followed his research, and was like, that really set me on the pathway to where I ended up today. So why is pH so important? Because in the mouth, every time you eat, your mouth becomes acidic, your teeth demineralize. This is a dynamic process that goes on and on every day. And then it remineralizes after you eat, and your mouth, you have enough saliva that raises the pH. Even some of the biofilm bacteria help raise the pH to protect the teeth, and then they remineralize. So you got this, ecological balance going on in the mouth. If we go back to the Stefan curve, from school, if you look at the blue line here on the chart and consider that to be the critical pH of enamel, which is generally about 5.5. So you wake up in the morning, your pH in your mouth is above 5.5. You have breakfast, it drops well below. In about 30 minutes in a normal, healthy mouth, pH recovers, you start to remineralize again. The calcium phosphate go back into the enamel. Then you have lunch, it drops, you lose calcium phosphate out of the enamel. Then 30 minutes later, you start to remineralize and you do the same thing at dinner. If you're on the East Coast and you just finished your meal right now, your teeth are starting to remineralize. You're starting to recover from that acidic episode. If you look at this graph in its entirety, there's more time above that blue line than there is below the blue line. So you have homeostasis, you're healthy, you don't have tooth decay. It's as simple as that. Now, if you just snack twice during the day, John Featherstone's research indicated that it dramatically increases your risk for dental caries. So just adding those two additional acidic episodes increases your risk for dental caries. And now if you start to look at the area above the line versus the area below the line, you start to realize, oh, it's maybe not quite in balance like it was. And then you've got the patients that are taking medications or they're getting older and they don't have the saliva output that they had. You have the patients that are taking 1, 2, 5 prescription medications, and we know the number one side effect of almost all prescription medications is dry mouth, some more so than others. But you take that patient that doesn't have enough saliva, and it doesn't take 30 minutes for their mouth to recover. It may take a couple of hours because they just don't have enough saliva. The pH of resting saliva is 6.75. Stimulated saliva, so you're eating, your stimulated saliva pH is already about 8. And so your body's already trying to protect your teeth while you're eating. But this could take hours for that to occur. And maybe some people, they don't ever really get back into good remineralization. Then you take the average American who's taking, on average of 2 prescription medications per day. They're eating 23 teaspoons of sugar per day. Those are averages. And we don't eat 3 separate meals. We graze. People, our diet today, we graze, we eat all day long typically. They're eating at their desk at work. They're eating in their car, driving to and from work. They're eating at their kids' game practice. They're eating when they get home. They're snacking before bed. I mean, that's how we eat today, the average person. Uh, it's a recipe for disaster. Your mouth never has an opportunity to recover. And so that's why we see all the tooth decay that we see today. That's primarily it. The challenge we have as dental professionals is we need to stop looking at this disease as cavities. We need to start looking at it as a whole person disease, where the environment, behavior, genetics, diet, all of that plays a role. And it's truly a whole person disease, not just a series of cavities. So one of the first places to start is with caries risk assessment. And the way to do that is with a caries risk assessment form. This is a form we developed over a period of 20 years using John Featherstone's validated research. And we tried to simplify it. Um, and we got the patients to fill it out and self-report their risk factors. 2 things about that is like you take that out of the hygiene operatory, so you're not impinging upon that precious hour of time that we've already overloaded with too many things that need to be accomplished. And when somebody self-reports a symptom or a sign or a risk factor, that has a lot more impact than you looking in their mouth and saying, "Oh, I see, it looks like you got a dry mouth." And the patient says, "No, I don't." That you're done. The conversation is over. You are never going to convince a patient, I don't care what you do, you're never going to convince a patient that they have something they don't perceive they have. However, if they tell you, yeah, I recognize I have a dry mouth, now there's the expectation on their part that you're going to talk to them about it. Yeah, what are we going to do about that? Right? Is that a part of my problem? What do we do now, doc? And my good friend John Coyce likes to say the caries risk assessment form is like playing Columbo. The value of this form, we all want to get to the bottom and circle the diagnosis. Is it high risk? Is it moderate risk? Is it low risk? We all want to come up with that diagnosis. When the value is why? We've got the dead body. Now I want to know who done it, right? For me, it's like you see the cavities in the patient, that high risk patient that we talk about. I want to know why. Who done it? So that QRS code here, you can take a picture of that. That'll take you directly to this form. You can download it and print it off, use it for free, modify it, do whatever you'd like to do with it. But and there are fee codes for that as well. Please use it. If you have the standardized form, you get to the point where you can start approaching those open-ended questions and try and get that information from them. This form is simple. The patient fills out the part above the line in the center, and it's self-reporting their risk factors, saliva, diet, and the biofilm. If they only have green answers on this entire form, they are low risk by definition. If they have at least one risk factor, by definition, they're moderate risk. And if they have any of the disease indicators, like new visible cavities, progressing radiographic radiolucencies, active white spot lesions, or a decay history, like they've had 2 or 3 cavities in the last 2 to 3 years, any one of those makes them high risk. And by definition, they become high risk. But when we talk about diagnosing the patient, and we got the form, the patient carries it in to the hygiene operatory. We said the hygienist typically is the first line of defense, for this patient. The caries diagnosis, we want to diagnose it hello, because if we make this complicated, it doesn't happen. Like the more complicated we make this, uh, the bigger the challenge is trying to incorporate it into your daily practice. And so one of the things that I worked on early on was we made it way too complicated, and we needed to make it simple. And if you think about patterns, we as human beings we see patterns, we look for patterns. That's who we are. Um, this was a study that we did, a clinical study that we did at Carie Free. 6 practices spread across the United States. We had over 12,000 caries risk assessment forms that had been filled out, self-reported by patients. 63% of the patients self-identified they had a dry mouth. 55% identified that their diet was a challenge. About 50% of them identified that they had a biofilm issue. We know that when we talk about the population at whole, that genetics play about a 9% role on the population. Now, for an individual, that could be 80 or 90%. But if we look at the population at large, we know it plays about a 9% role. So it's not huge, but it's there as a factor. But at the end of the day, dental caries is all about pH. If you have those prolonged periods in your mouth of low pH and you have irreversible mineral loss, you have dental caries. And if you don't have that, you won't get this disease. So it's as simple as that. I want you to think about this for a second. We're going to look at kind of what those patterns look like. But I want you to think about this for a second. 63% of your patients probably have a dry mouth. 70% of them are taking at least one prescription medication per day. 63% of them on average in this survey report a dry mouth. If you walk into a new patient, you never looked in their mouth, and you said, "Oh, I see you've got a dry mouth," you'd be right 2 out of 3 times without even ever looking at the patient. Those aren't bad odds when you stop and look at it. Um, so what do these patients look like? Well, typically they have a lack of saliva, there's dry tissue, they're taking medications, and they identify it sometime during the day or night. They feel like they have a dry mouth. This patient came to me, she was in her early 40s. She suddenly started developing two new cavities per year. And she'd been decay free until about 3 or 4 years prior to that. Her previous dentist and hygienist told her that she needed to brush and floss better. I want you to take a good look at this photograph because this is what we were taught to tell people. Oh, you got cavities? You're going to fix this with a brush and a piece of string. This woman, she has a 0 plaque index. She doesn't need to brush and floss better, but take a good look at this photo. What don't you see? There's no saliva. I had to pry her cheeks off, and then it's easy to take a photograph like this. Typically, you have saliva bubbling between the teeth and pooling, and it's hard to get a clean shot like this. This woman had no saliva. She was taking 2 prescription medications for anxiety and depression, one of which is extremely causes a severe dry mouth. So this wasn't a function of her home care. This was a function of the environment based on the medication she was taking. I want you to take a good look and imprint this one in your brain. This is what sugar looks like in the mouth. You'll see cavities just everywhere. It's like you'll see them on, the class 5 on number 27. If you see cavities on the mandibular anterior teeth, you've got a really severe high risk caries patient because those are the most protected teeth in the mouth by saliva. I mean, those are the last men standing. If there's only 6 teeth left in the mouth, which ones are they? If there's only 2, which ones are they? I mean, we all know that, right? So when you see cavities spread everywhere, that's from sugar. If you see a lot of cavities in between the teeth, and approximately that's from sugar in solution. And we're talking about sugar sweetened beverages. But you look into a mouth like this, um, and I immediately go, I know I'm going to talk about diet, right? And I've got the form here filled out, but I know that I'm going to ask some, open-ended questions. Tell me about your diet. Tell me what an average day, typical day looks like for you. Tell me the kind of things you like to eat. Um, Biofilm, if they notice plaque buildup on their teeth, or if you're using a caries screen meter, which measures just bacterial load primarily, um, then you know that you've got a biofilm issue, right? Typically, you see that plaque buildup on the teeth. So that's pretty easy to recognize as well. I want you to take a quick look at this. This is a young person. This was published this data was published in about 2013. We identified that a lysozyme, a mutation on the lysozyme, the lysyl-2 gene, causes decay only in the mandibular incisors. So if you ever see this, and I literally read this study 2 weeks before this patient was referred to me by a pediatric dentist. And when I read the study, I thought, nah, I don't buy that. It just doesn't pass a smell test. I've never seen that. I don't have a hard time buying that. this patient, 2 weeks later, this patient walked in the door. I took one look at her, looked at the mom, and I said, she's got a mutation of the lysozyme on her lysyl 2 gene. And they looked at me and thought I was like, the smartest man in the universe. But it was literally, if they'd come in 2 weeks earlier, I'd have had no clue. But I've seen this 3 times now in my practice. So just file that one away. That's a genetic issue. But at the end of the day, we always come back to pH. So then we get into treatment strategies, like what do you do for these patients? What if they're low risk, moderate risk, high risk? How do we handle that, right? The big question comes into when do we restore? And this is, I got to tell you, AI plays a major role as we get into this topic now. And it plays a major role in, I mean, Sheila's going to talk to you about this, but it plays a major role in identifying early lesions, and it plays a major, major role in the patient being able to see them and understand what's going on. When I had my CT scans and the x-rays, they used an AI program. I mean, that's standard of care. And I actually got to sit down with the radiologist and go through it. And of course, I've got a lot of experience looking at x-rays, but maybe not necessarily at cervical x-rays. But I could clearly understand what was happening or what had happened in my neck. The same is true for your average patient when they're looking at these x-rays that we even the digital ones we put on a big screen. See this spot right here? Well, when you can highlight and demonstrate it to them, it's very, very impactful, I have to tell you. One of the things we need to, the defining line between restoration and remineralization is it cavitated? If there's a hole in the surface of the enamel, the bacteria are able to invade the teeth. If there is no hole in the enamel, the bacteria haven't invaded the teeth necessarily, and we have an opportunity to remineralize it, restore the tooth without a drill. Now, as we look at some of the data, on some of these studies, and this one was done, they actually used orthodontic separators in between the teeth for a week and then separated the teeth and looked at them. They could actually see whether it was cavitated or not. But the interesting thing about this is that the E1, E2, E1, E2 lesions, most of those are not cavitated. So when you see what we used to consider the classic board lesion, most of those, a significant majority of those are not cavitated, which means you have the opportunity to repair those by remineralization. And even true with the D1 lesions. And if we look at data, this is data from yet another study that was published in 2022. Those enamel lesions in the outer half of the enamel, the E1 lesions, only 2% were cavitated. So there's a lesion that I would hesitate to put a drill on, right? 98% of the time, I know that it's not cavitated. I'm going to try some remineralization strategies with that first. Curidon, nanohydroxyapatite fluoride, etc. The E2 lesions, that's where it's penetrated all the way through the enamel. Only 10% of those are cavitated. And here's where it gets a little bit tricky. The D1 lesions, that's a third of the way into the dentin radiographically. 35% of those were cavitated. That means that 2/3 of them basically were not cavitated, but the challenge is, but a third of them are, right? So you have to use your professional judgment at this point based on their caries risk, based on your history with the patient, based on the patient's desires and needs. Am I going to open that up or am I going to try remineralization first? And the progression of the disease, if you have some history with this patient, maybe it's not a good idea to wait 6 months, or you have a kid that's getting ready to go off to college and you may not see him for 3 or 4 years. You have to make that professional judgment. Um, it's coming. It's coming. I promise you it's coming. The day is coming when AI will be able to tell us with a high degree of sensitivity and specificity whether these lesions are cavitated or not. And when that day comes, in my mind, that will be the biggest advancement in dentistry since radiographs in the first place. Because now I'll be able to sit down with a high degree of confidence and say, this is cavitated and we need to do a filling, or nope, it's not cavitated. We have an opportunity to remineralize it. When you look at the D2 lesions, 41.5% were cavitated in this data. And by the time you get to D3, that's the inner third of the dentin, 85% of them were cavitated. And we all know that if you wait that long, you could well be doing a root canal. You could have some pulp vitality issues. So somewhere in there in that gray zone, we need to make a decision on when do we drill, but also recognize that we can identify these lesions earlier, particularly the ones that we have an opportunity to remineralize. And so on occlusal lesions, we have the ICDOS classification, caries classifications. There's seven stratifications here. The 0, 1, and 2s don't need any treatment. Typically, we'd recommend sealants there. But 3s and 4s, you're probably going to do a little e- exploration of the tooth, maybe provide a preventive resin restoration there. But obviously, 5 and 6 cavitated lesions, you're going to need to like place a restoration. The ADA Council on Scientific Affairs said, here's the protocols, here's the ideas on how to treat dental caries medically. Treat the disease from chemically, not from using a drill. And they list 38% silver diamine fluoride, which I'm sure you guys are all using, sealants, 5% sodium fluoride varnish, acidulated phosphate fluoride gel. I don't think many people are using that today, but then a 5,000 part per million fluoride toothpaste or gel, and they recommended against the use of basically MI paste for treating the disease. So let's go back to the treatment strategies. Let's go back to our risk factors and how are you going to look at this? So I think I'm going to present 5 different strategies to you here tonight. There's a couple more I'll mention, but sodium hypochlorite, we need, an antimicrobial strategy. Sodium hypochlorite, resets and restores the biofilm. It has a high pH. We're trying to get that pH back to a healthy biofilm. And pH neutralization, we know that raising the pH changes the biofilm, just like dropping the pH changes the biofilm. Nanohydroxyapatite, there's a flood of this material on the market. I'll talk about it briefly and kind of help you understand, maybe sort through some of the materials that are out there. Fluoride's been around since 1945 and has, the benefits are well established. It's also probably the hottest controversy in the public's mind right at the moment in dentistry, and particularly community fluoridated water. And then xylitol, which we know has an impact on the bacteria as well. We talk about pH neutralization, and it's like pure water has a pH of around 7. At 5.5, enamel starts to demineralize. Most of the things we eat and drink, and a lot of oral health care products are acidic, and many of them are below the 5.5 pH. So one of the things I started working on when I work with Philip Morris 25 years ago was I'd like to have a product that was alkaline that's going to help drive that pH back and correct that biofilm. And so we created at that time, the first alkaline oral healthcare system, challenging to get shelf life stability out of an alkaline product, but we figured it out after 4 years on a team of engineers. So one of the things we know, this was a study done at Intertech Laboratory in London, an independent test, standardized test where they would take a biofilm model, treat it with an oral healthcare product, and then challenge it with sucrose, and then see what happened. And so the carie-free 5,000 gel here raised the pH of the biofilm about a half a point up to 7.73. And after 20 minutes of continuous sucrose challenge, the pH was still at 7.22, whereas the control dropped to 5.26 in that 20 minutes, which is, below the critical pH of enamel. Jorgen Slot started publishing work on using sodium hypochlorite back in the early 2000s for treating periodontal disease, inflammation, gingivitis, bleeding, probing, all of those kind of parameters, and plaque level. And I've used chlorhexidine, povidone iodine, etc. But I really didn't get the results I was looking for until I turned to like sodium hypochlorite. And so it's safe that we've been using it for forever. And one of the challenges that's been raised on antimicrobial rinses was that it reduces the number of bacteria that are nitrite reducing. And so reduces the amount of nitric oxide coming from the mouth, which is about 20% of the body's nitric oxide, which nitric oxide relaxes the smooth muscle cells in our blood vessels. And so it helps lower our blood pressure. So by putting a patient on an antimicrobial rinse, what we've seen in a lot of the research is that a lot of those rinses increase the blood pressure even just after like using it for 7 days. So I have data. I did research through the Forsyth Institute at Harvard back in 2008 through 2010. And I went back to look at my data because I wasn't interested in that at the time. I was interested in, can I control the mutant streptococci and the lactobacillus? Can I help create a healthier biofilm? And when I went back, it was very interesting. What I found was that it not only did it not decrease those nitrite reducing bacteria, it actually increased the levels of them. So we ended up with a much healthier biofilm as a result of that. So I would tell you that I never published that data, but I've got it. And when we talk about nanohydroxyapatite, the first question, the most important question to ask is not what percent do you have, etc. The most important question is where does it come from? Because the only nanohydroxyapatite that's been tested and studied and proved to be safe. There's a second one now, but the only one that's been proved to be safe, and the only governing body that's regulating it right now happens to be the European Union, the Committee on Consumer Safety. And they looked at it, so we know that there are no needle-shaped particles in this. They are typically rod-shaped, and we now know also that uh, spherical shaped particles that come from like eggshells, those particles actually invade and have more cytotoxicity, like in renal epithelium, that was a study, than say needle shaped particles. So the biggest concern is where does it come from and what are the size and shape of the particles? Not the percentage. That's not as important in that factor. Um, and we talk about fluoride. It's really important to recognize that fluoride is a, not a remineralizing agent. It's an anti-caries agent. Now, it plays a role in remineralization, but it's not a remineralization agent. It's not considered that by the FDA. It's actually considered an anti-caries agent. So what does it do? Well, the fluoride is the strongest negative charged small ion in the entire periodic table, and it has a strong attraction to calcium ions. And so it's highly reactive. It does four things in remineralization. It reduces the microbial acid production of the biofilm. That happens to be potentiated by xylitol. It accelerates remineralization by attracting calcium ions into the field. So it's like the fluoride present, it's attracting calcium ions, which also then attract, in turn, phosphate ions. And we get this remineralization process, and it acts as an accelerant or a catalyst. It enhances remineralization by increasing the degree of crystallinity in that remineralization process. So you have a higher density of the remineralization than without it. And it makes the enamel, the last and not the least, it makes enamel more resistant to demineralization. So the critical pH of hydroxyapatite is 5.5. The critical pH of fluorapatite is 4.5. So it makes the enamel more resistant to demineralization. Now, the hot topic, and we don't have time to get into all these controversies, but just understand that we have a lot of fluoride available. It's virtually in everything we eat and drink. And it's in all of our oral healthcare products. I mean, fluoride is everywhere. We're using varnish, et cetera. It's in the water. And the question has been raised, well, with all the other fluoride, do we still need fluoride in the water? Is that even a valid thing today? And this comes from the CDC, and this was in 2023. They still estimate that the fluoride in the community drinking water reduces the decay rate in the United States by about 25% every year. So it still plays a role in our drinking water, but it does come with some systemic risk, and we're all aware of those. Fluoride and xylitol, I said it potentiates that. So xylitol is a great strategy to use alongside fluoride. It's great by itself. Xylitol chewing gum, xylitol mints, etc. And we have some great research on that. There's a lot of data on xylitol and how it impacts this disease as well. This was a product we ended up making, the ProGel 5000. It has 5,000 parts per million fluoride. It has a proprietary amount. You can't just mix because of the attraction between fluoride and nanohydroxyapatite and the calcium ions there. You can't just mix the two together. There's a very narrow, specific window that you can mix that we did the research on to figure out what that is. But when you mix that and you hit that, it's magic occurs. and you get great remineralization results. And the pH is a pH of 9, and it's sweetened with xylitol. I think it's 28% xylitol, has a low abrasivity, and it's not a designer toothpaste. This is something that we designed from the ground up based on all the research, and then we do our own research on it and test it for efficacy to make sure that it works. This is one of the pilot studies that I did, and we actually published this back in 2013, but through the Kutsch Center, the research center there, we started working with non-hydroxyapatite and saw deposition immediately on artificial lesions. This was in bovine enamel. And then this was, again, remineralization using standardized protocols that we use in the industry for testing microsurface hardness and remineralization results. And we got to 73% microsurface hardness in just 3 days with this gel. And if you want to look at just, this is an SEM study we did earlier this summer at Oregon State University in the chemistry department. Um, on the left, this is bovine dentin, and we've applied in the same protocol throughout. This was we had a distilled water control, then we had this for comparison. This is a 5,000 part per million gel that's on the market. And those are the open dental tubules you see there. In the center is the same protocol. This is the Carie-Free ProGel 5000, which has that proprietary mix of fluoride and nano HA, which, by the way, is from Nano XIM Fluid Nova. We were their first customers, first people in the United States to use that. We use the medical grade of this, by the way, as well. And then we figured out how to get that Nano XIM to a concentration of 10%. You can see the remineralization results there. That you'll see that product introduced about mid next year. It's almost through completed stability testing. So we talk about treatment protocols then. Again, we go back to the risk factors drive your protocols, right? So, if they don't have a biofilm issue, I'm not putting them on an antimicrobial agent. That's a waste of time. If they don't have a dietary risk factor, there's no point in me discussing, how can we help modify your diet to make it safer? So those suspects drive your treatment strategies. If they have a dry mouth, you want to talk to them about hydration, staying hydrated, and neutralizing the pH of the mouth, stimulating the saliva, xylitol mints, xylitol gum. Make sure the water they're drinking is neutral. About half the bottled waters are acidic and have a pH of right around 4. That's for shelf life stability. So just make sure that, if they're drinking a lot of bottled water, tap water is the safest, easiest thing to drink, but just, help educate them on that. The diet typically comes down to either they're eating too much sugar or they're eating too frequently. And so you can, get that by asking them the questions and then just help them create some ideas on, well, how might you modify that? It's okay if you're going to have the sugar sweetened beverage, or if you want to have a candy bar or whatever it is, have it in conjunction with a meal. Have it at one time, eat it, get that acidic episode over with, and let's get the mouth back into recovery. Don't nibble on the big bag of M&Ms all day long, right? If you're gonna have the M&Ms, I'm not gonna stop you. That's great, but do it all at one time. Get over with. The biofilm, it comes down to, do they have a high plaque load? You're going to want to use an antimicrobial strategy. For me, that would be the sodium hypochlorite, the Carie-Free treatment rinse, and some of it may be home care, right? And so it may be a matter of sitting down and helping them become more effective at their brushing and flossing. And if they've got you suspect a genetic issue, everything else you can't, you come up to a 0 on. You just want them to understand wellness and trying to support a healthy environment in their mouth. So the patients with low caries risk, those are the DO601s. These are healthy people. They don't have cavities. They don't have risk factors. You literally don't have to do anything for them. They're healthy. You just want to keep them healthy. And I want the patient to know about risk factors so that when they come in a year from now on their exam, I'm going to ask them, is there any change in medical history? Is your diet changed? Are you taking any new medications? Has anything changed? Because that could dramatically affect your risk for dental caries, for decay. So, I'm going to offer them a varnish, fluoride varnish. I'm going to offer them strategies that have, pH xylitol nano fluoride. And if they don't like fluoride, I'm going to offer them one that, has a pH xylitol and nano HA without fluoride, and we have a naturals rinse, again, that is very effective, on the biofilm and doesn't have fluoride in it. Now, this is the person that has at least one risk factor, and you really want to help them mitigate their risk factor. So you kind of target their risk factor. I'm going to recommend seeing them twice a year. I'm going to recommend a fluoride varnish both times. I'm going to recommend that, fluoride gel, the Carie-Free Pro Gel 5000. If they're fluoride averse, I'm going to recommend a Carie-Free gel that doesn't have fluoride in it. And again, I would recommend the Naturals rinse if they're adverse to fluoride. For the high caries risk patient, these are the people that have cavities. Um, again, I'm gonna see them 4 times a year. They're gonna get a fluoride varnish every 3 months. That seems to be the peak of the activity and benefit from fluoride varnish. Again, I'm putting them on a 5,000 part per million fluoride gel, unless they're averse to fluoride. In that case, I'm going to use one that doesn't have that. I may or may not use the treatment rinse depending upon whether or not that they have a high bacterial load in their mouth. I will or will not use silver diamine fluoride, depending upon how many cavities, where they're located, the wants and desires of the patient. Are we trying to phase out treatment, etc.? So, but that's a possibility. And then I'm going to do the behavioral coaching with them, targeting their risk factors again to see if I can't help them become decay free, help them understand what's driving their disease, and then being able to see if we can get them decay free. So we're going to save the questions for the end, but just wanted you to know, take a screenshot of this with your phone. Sheila's going to come on here in a second and talk to you more about Pearl and AI and what that can do for you, particularly for these caries patients. But there's an exclusive offer, a carry free with the code PEARL50. You get $50 off on your first order or whatever. You could schedule a training webinar for free just to learn more about what we talked about tonight and how to implement that in your practice. And with that, Sheila, I'm turning this over to you and I'm going to hit stop share so you actually can. Oops.
Excellent. That was so incredible. And I am beyond thankful that we have this recorded because there was so much information in there that I can't even begin to digest it. So, everybody on the call, you will receive all of this information. And stick around because we are bringing Dr. Kutsch back to answer the questions. There's a lot of questions in the chat and in the Q&A. Feel free to dump them in. We will bring him back in just a minute and walk you through how to go about questions like the MI paste and how to really, I like what you said is that the risk factors drive the protocols. And so I'm going to share with you kind of a interesting story. This is my really great best friend Cherie and her daughter Kendall. And I actually messaged her tonight and I'm like, "You're still okay if I share your face across the world tonight, right?" And she said, "Yes, if it's going to help stories and patients, great." But I feel like this is the perfect patient that tells the story that we're talking about. And as a hygienist myself, working with patients for many years, before I started into practice management, these were always the stumping patients, meaning didn't accept enough treatment and even possibly were questioning the diagnosis. And then the third part is once we do decide to treat patients, how do we navigate through changing their behavior and coming alongside them so that we don't have a repeat of this scenario? Now, I want to take a step back for just a moment and tell you that my friend Cherie had brought Kendall into our practice, and we call her Kate Stewart, but I'm going to tell you she gave me permission to share this. And she said, "Your practice is crazy. They told Kendall she has a ton of cavities." And I said, "Well, we're not crazy. I've been there 25 years. They're great doctors. What do you mean?" And so I met her at the practice, and we walked in, and she saw this image. And I said, "This is what the doctor sees. This is what you see." Okay. Now, the good news here is with Pearl happening in real time, you don't have a delay and you have a built-in second opinion. I think it's really powerful that the colors change based on that enamel lesion versus those lesions that are moving into D1, D2. So this was a big eye opener for step one, which is accurate diagnosis. And then step two, we'll move into correct treatment planning, right? So it's really important that we know that we have a lot of arsenal. We have caries risk assessments. We have a lot of products. But we were talking before the call started, Dr. Kutsch and I, and as many years, I think we have over 75 years combined, which is scary. But cavities are still here, right? And what are we doing to really move past this phase where we have all kinds of patients that still have cavities? And once we do decide, are we just going to fill number 30 distal, or are we going to fill any? What happens to Kindle in 3 years? And I think that's the most important conversation here is assessing the risk, making sure we can present the dentistry so the patient can be alongside on this journey, right? It's one thing to just move over to you have 10 cavities or you have 2 cavities and I'll see you Tuesday. But a patient like this could struggle with this lifelong. So having AI for us to be able to have that second set of eyes, AI doesn't get tired, right? And to turn it to the patient education side. It's a big win for patients to be able to see what you're seeing. And this isn't just for new patients, right? This is for your existing patients. And I remember again walking into all my appointments and I would look at all this unscheduled dentistry and I'm thinking, why are they not getting these teeth filled while they're small? Or why are we putting off this scaling and root planing? And it's unfortunate circumstance that our patients still have a hard time understanding what we're explaining to them. And we all, I think, agree on this call that there's still that distrust in our dental space. So as you look at incorporating AI into your daily workflow, I want to let you know after working with thousands of practices and my own team alone, that it's a simple switch. You turn it on, it's able to work in real time, and it's really one area that doesn't get tired, right? We all are aware of diagnosis fatigue. I thought it was interesting that Dr. Kutsch brought up these different caries levels, these E1 through D3 lesions and that classification. And I'm excited to share with you guys today that this is coming out in Pearl to provide additional areas for you to navigate through your images with more data to make those definitive decisions and when to decide to wait and remineralize. So we're very excited with our clinicians we work with at Pearl to be able to make sure we're in complete alignment. And keeping in mind that AI is not here to ever take someone's job. That's a lot of the questions we hear, but it's here to provide additional set of data. And again, as you navigate through those millions of x-rays that clinicians do on a daily basis. And as we look back at the history of modern dentistry, and we've seen the technological advances that have truly pushed our industry forward, we're at a new dawn here of almost full adoption into AI. My 4th year here at Pearl, in the beginning, it was, I don't know if I need AI. And now when I meet people at conventions and stuff, the question is, well, which AI company am I going to use, right? So I think that's very interesting. But you guys have all seen this, and it's interesting. The statistics are pretty similar to what we talked about with cavities and dry mouth, but 64% of patients don't understand what we're showing them on radiographs. And we are all guilty of standing in front of an image. And I used to hold a pencil up to talk about bone levels when I was discussing scaling and root planing. And it's really a wonderful addition to have, again, not only images to help you provide more information as you move through your own decision-making process as a clinician, but to be able to have that conversation with a patient. And the silver lining here in adopting technology, as I've seen over thousands of practices, you're buying back time. And that time is spent on things that we love to do, which is establish those relationships with our patients. And I think that's the interesting part that people don't talk about with the addition of technology, because we're also a lot of, we fear technology and we hear about it in the media, and it's going to take our jobs and stuff. And what I want to let you know here is think about ways to create using technology where it's going to do some mundane tasks for you and also, chart audits, insurance verification and stuff. But ultimately here, when you're able to show a patient an x-ray in color and you see about a 3 to 7 minute savings of time for yourself as a clinician, that's when you can talk to your patients and find out what is holding them back. What questions do they have, right? And again, as much as our industry has really changed, we still have the statistics that show that there's a lot of inconsistency in the diagnosis. So I think one that's very interesting is that 20% of caries diagnosed are not actually caries, right? And remember that the AI can see thousands of shades of gray, whereas the human eye can see closer to hundreds of shades of gray. So I think that's valuable when you're looking at navigating through those radiographs. One of my favorite things as we wrap up and move into questions here is being able to share with pediatric parents, right? I remember when my son first got a cavity as a hygienist, I had a heart attack, but I slowly moved on. But a lot of times patients would say, or parents would say, well, the teeth are just going to fall out. So why are we putting a filling in, right? So again, as we move into full alignment with clinicians, we're moving into fun things like sugar bugs and cavity bugs and patient education and parent education. But really, this picture to me is what it's all about because all of the things you invest in a daily basis, it's all about making sure the patient understands what's really on in their mouth so that they can make that informed decision. And earlier they make it and the more often, the better. So I want to make sure that I do invite you to scan this QR code, take 15 minutes with one of our team members, and see if that using Pearl is a good match for your team. Whether you're using it for, real-time information that provides cavities, periapical radiolucencies, calculus, notable margins, those types of pathologies on your images. And remember, one spacebar button and your image goes back to its native origin. So it's just that second set of eyes. We are embedded in over 32 different imaging systems, and we do work with chart audits, insurance verification, and there's many things that might be a great fit for your practice. So I'd invite you to scan this code, see if it's a great match for you. And also, I want to bring Dr. Kutsch back on to answer some of these questions that we have received. And let's go ahead and see what I have here for my questions. So let me stop sharing for just a second. Okay, here we go. I'll put the code back up in just a couple minutes, but let's start. Are you ready, doctor? This is going to be
Yep.
like
Yep.
questions.
Fire away.
Okay, number one, why is MI paste not recommended for remineralization?
Okay, so what I said was it's not recommended for caries treatment. It can be used as an adjunct to fluoride for remineralization. But if you go to the Cochrane report, which is our most pure science, the most unbiased science, and they do systematic reviews of all the published literature, they just don't, there just isn't data to support it.
Love it.
Yeah.
Okay, now here's another question.
Yep.
Can you do too much fluoride? We get asked a lot from patients. Can I suggest the high fluoride, such as carie-free, and the
Mhm.
fluoride rinse if they are moderate and high risk?
Yep. Yes. And the other thing that I would say too is particularly you have to be concerned about fluoride exposure primarily with children, like if you're using fluoride varnish. You really want to be careful with your dose. And and the research that's been done shows that there's an increasing benefit up to 4 times per year, but actually then there's no additional benefit beyond that. So to do it 5 times a year, 6 times a year, 10 times a year, there's no increasing benefit beyond just doing it 4 times a year. But in terms of is it safe? Yes, and actually that's a very interesting question because one of the topics is the controversies today is certainly around community water fluoridation and the systemic risks that come with fluoride, right? Well, you're actually ingesting fluoridated water, so you get those systemic risks. Well, number one is fluorosis on the teeth that we all identified, but number one is interfering with the TSH and T3 thyroid hormones, and that occurs down to a water level of about zero point 0.5 parts per million, which is below what we're putting in the water at zero point 0.7 parts per million. And then it appears to be dose dependent. The delayed development of neuronal cells. So like in developing brain cells, it delays development and may end up with a lower IQ in children. But that appears to be dose dependent above about 1.5 parts per million, and below that, there is no correlation in that relationship. But obviously, those are concerns that we have, that fluoride, has that effect or impact in the body. So one of the questions that I've had this year is, well, what is the systemic? So let's forget the fluoride in the water. Let's just say we have, because it's available in our toothpaste and in our gels and rinses and what have you. Well, what's the systemic impact of just using a fluoride toothpaste, right? What is this? We're using a topical, and the benefit from fluoridated water is primarily topical anyway. So you're getting the topical benefit of the water on the teeth, but then with the systemic exposure, whereas you could get the topical benefit using the toothpaste or the rinse, and then, well, what is the systemic exposure? So I did a small study with 20 people from age 6 to 70. I put them on a non-fluoride toothpaste product for 2 weeks. I measured their urinary fluoride levels. Then I put them on a fluoride product, an 1100 part per million over the counter toothpaste for 2 weeks, and there was no significant change in their urinary fluoride levels. So what tells me is we're not ingesting a lot of the fluoride from that. So it appears to be safe. Now, that was a small study, small sample size of 20 people. Um, and we were using urinary fluoride, which we tried to collect at the same time every day in the morning. But obviously we didn't, and that was the only variable was no fluoride toothpaste and fluoride toothpaste. Um, so it appears the magnitude of your systemic exposure to a fluoridated oral healthcare product is minimal, if to non-existent. So you could safely use that. So do you need to worry about putting people on a 5,000 part per million? Yeah, as long as they're not swallowing it, but when you get below about the age 5, children tend to swallow a lot of stuff. It goes in the mouth, it goes down the throat. Um, so you have to be careful with fluoride, particularly in young children, just in terms of overall exposure. But anyway, I hope that answers the question. It's a
Excellent.
great question, by the way. It's one we should be asking.
There's a lot of great questions in here. So one additional question real quick is Carry Free available in Canada?
Yes, it is.
Okay,
So
great.
the distributor, yeah, if you'll contact the company, it's available in Canada. The distributor there is National Dental. And yeah, you can get all the products there.
Excellent. Okay, some people are partially compliant. Oh, we all know that. They want to use high fluoride toothpaste once a day, then another toothpaste as well to get that clean feeling. What are your thoughts?
I don't have a problem with that. If they're using a toothpaste, well, be careful with that clean feel because a lot of the toothpaste on the market, particularly the whitening toothpaste, have an RDA of like 250. I mean, they're the maximum FDA allowable limit. I think the ADA's limit is recommendation is under 200. So you'll actually wear the enamel off the teeth if you use those consistently. So you have to be careful with those. If you want to use one of those like once a week, that's probably, or once a month, that's probably safe. But if you use just one that has an RDA of relative abrasive index, somewhere around 70, uh, once a day, you're not going to do any damage, shouldn't be doing any damage to your enamel. And we know the bristle brush plays, the hardness or the firmness of the bristle plays a role in that as well. But yeah, if they did that, then I would use like the Carry-Free gel at night, right before they went to bed, spit it out, leave the rest on their teeth, and that's how they get the best benefit from that.
Mhm.
Yep.
Okay, there's a question here about what are your thoughts on using the product Curadont plus Carry Free Pro Gel 5000?
I think that's a beautiful plan.
Okay.
So the thing that you need to understand about Curadont, that is just a self-assembling peptide. And that P11-4 goes down inside of penetrates into the, porosities in the lesion and creates the infrastructure that then the crystallites, the nanocrystallites of hydroxyapatite, or the ions, depending upon, again, probably a combination of both, but are attracted to and actually then assemble to create that remineralized enamel. But so Cure Not by itself doesn't remineralize anything. It still has to have calcium phosphate to remineralize the enamel. So using a product, elevated pH like the Carry-Free Progel 5000 that has fluoride that's going to accelerate it. It's got nanohydroxyapatite that's the most biomimetic size that to remineralize teeth with. That's like, as far as I'm concerned, that is like the perfect recipe.
Excellent. Okay, let's see. There's one more question here. Um, so
Hey, don't
there's
worry, I stumble over that all the time.
particles have toxicity depending on particle shape, question
Yep.
mark. Can you
Yep.
cite the research articles that show this?
Not off the top of my head, but I can, if you'll send an email to me, I'll get those to you. Yep,
Perfect.
absolutely. Yeah. And obviously the concern was originally was needle-shaped particles because we know that they penetrate soft tissue, have the ability to travel throughout the body actually. So that's always been a concern. And I think it was 2019 that they actually determined looking at different shapes on renal epithelial tissue that actually spherical shaped particles had a greater penetration than even needle shaped and created more cytotoxicity. But I'll get that if whoever asked that question, if you'll email me, I'll get you that's those studies for you to look at.
Thank you. And great question, Cheryl. Kimberly, our wonderful co-host here at Pearl, our Director of Partnerships, has also put in the chat Dr. Kush's email. So we also
Perfect.
have the website was put in for Karina, who asked about Canada. And I think the questions are finally slowing down, which is good, although we're here all night, people, so feel free.
Yeah, these are great questions, by the way.
Great questions. Okay, we also have put your email directly into the webinar chat for everyone. And again, great news. This will be recorded. Would recommend you share this, take notes, dissect it, order some products, right? I know I'm gonna do that with my practice, but I guess the last thing I would say here is what would be the number one thing you would start with tomorrow in a practice where you identify high caries patient that we've all done these interesting protocols, like I was telling you earlier, that we feel like we've been taught. But what would be the one thing you think you would change? Would it be the risk assessment? Would it be changing that first process?
I would start with the caries risk assessment form. And not that that's the end all, but it directs you to open the question. You know which questions to start asking. Is this is it a dietary risk? And it could well be a combination of diet and saliva. It could be a combination of all of them. But being able to target in then your questions to understand what's causing their disease. From there, everything else is logical and just flows. But you've got to have that right diagnosis from the risk assessment form, and to be able to ask the right questions. It's like I had a patient. I'll share this one patient story with you really quick. I had a patient referred to me. He was a veterinarian, mid 40s. The man was an ultra marathon runner. He was a specimen. I mean, this man walked in, he was like 6'1" and probably weighed 175 pounds. I mean, he was zero body fat. He was running 100 miles a week training, right? I mean, I looked at him, I was just like, wow. Uh, okay. He started developing, like, when he started this running, he started developing like five cavities, new cavities per year. And before that, he'd been decay free. And so his dentist referred him to me. They were both frustrated, couldn't figure it out. Referred him to me, and so I sat down with him and I said, "Well, tell me about your diet. What does an average day look like for you?" So, I mean, he's got like a Mediterranean diet. He's like, everything is like ideal. And I'm like, wow, this is really interesting. So I'm thinking, so you run like 20 miles at night after work. Yeah. And I'm like, rain or shine, pretty much. I'm like, okay, so you must carbohydrate load. Like, I mean, don't you need a carbohydrate load? I'm not a runner like that, but I would think that you're doing something. Oh, yeah. I have goo, which is a product for runners. And it's like, I'd never heard of it. He goes, I have goo. I eat 5 packets a day. I keep it in my clinic pocket. And he literally was squirting all day long, 5 packets of goo in his mouth. And I'm like, I have no idea what this is, but we're getting somewhere. And my assistant was a runner. She goes, I have a pack of that in the car. And I'm like, stop the press. She runs out, she gets it, she brings it in, and I read the label, and it's like dextrose. So it's sugar, oil, sugar, some water, and some um, electrolytes. And I'm like, this is frosting. And, with electrolytes, it's like frosting. And he looks at me like his eyes were this big, but it's healthy. It's for runners. And I said, yeah, but look at the ingredients. This is how you make frosting, for crying out loud. And it's like, what do you think would happen if you ate a little packet of frosting or frosting like continuously all day long? And he goes, I'd get a lot of cavities. I'm like, yeah, you would. You get like 5 a year, evidently. And he was like, that's it. I'm like, that's it. Like, that's all it's going to take. But then it was like, well, what do I do? I said, well, is this possible? Could you eat all 5 packets at one time an hour before you run and then rinse your mouth out with like tap water just to get the pH back? Oh, yeah. He did that. He became decay free. Went right back to be. So he was just doing some one little thing wrong. And I see that a lot with patients that if you just correct that one thing, that's the difference between health and having, chronic tooth decay. But they don't know, right? And so that's where we have the opportunity to help them. And so I think for me, that one thing is start with a risk assessment form. And you don't have to start with every patient. You could start with every new patient, or you could start with, who the high caries risk patients are in your practice. You know who they are. You know them by name. Start with them. And then kind of work it into the practice so that it just becomes everyday standard of care. Everybody gets one once a year because their risks change over time. So that's where I'd start. But after that, I mean, once you have that right, the rest of it is easy to sort out, right?
I think you're spot on, and taking the time to do that is our job, but also the gift to the patient, right?
Yeah,
Back to Kindle, we figured out that she was eating Altoids because she went into a new job after college. And once we stopped those, right? So
right. That's all it took.
pretty much the chewable goo, to your point.
Yeah, yeah,
So
exactly.
I love this reminder, though. We really have to slow down and get behind the eyes of the problem and not continuously treat the symptoms.
Yep, exactly. Because obviously that approach we've been doing for the last 150 years and it's not working, right? It's not working. You know,
Absolutely.
if it worked, it would work. And you and I wouldn't even be here tonight, right? Talking about
Exactly.
this, right? Nobody
That's
would have tooth decay and we wouldn't even have this topic. So anyway,
Well, I am so thankful that and honored to be able to spend this time with you and everything you have shared with us tonight. It's changing lives. Even coming to this with a broken neck, that's pretty impressive. So thank you for that. We wish you lots of healing. Keep in mind, those of you that are on this call, you will receive that webinar, but also on hellopearl.com. There's a lot of additional educational resources. We will be doing webinars all of next year. And if Dr. Kutsch lets us, we will be bringing him back as
oh,
well
I'd love
because
to. I'd
it's
love
such
to
an
be back.
important topic.
Yep,
And please feel free to reach out to us. Either one of us, we'd love to help you in any way we can.
yep.
And
If I could be a resource, and Sheila, thank you so much. Just being able to be here and share that. I know I shared a 1 day program in 40 minutes. So there's a lot of material there. But I hope that it just sparked the interest of like, yeah, this is doable. And I mean, we have thousands of dental practices in the country now doing this like every day. So it's like it can be done, and it's wonderful. When you can help patients like that, it's life-changing.
That's a great statement to end on. Thank you
Yeah.
so much, Doctor. Thank you to all of you who attended, and we look forward to seeing you all on the next webinar. Have a wonderful night, and we'll see you soon.
All right,
Bye-bye.
bye everybody.